One of the earliest patients I enrolled on the study developed a full classical ST elevation myocardial infarction, so like the big heart attack. And it happened infectively just a few weeks into him starting hormonal therapy. And he had none of the sort of major risk factors of someone who we would expect to have a heart attack. And so when that happened, it really started to trigger me to think about what are the long-term and short-term consequences of hormonal therapy, and then recognizing that we are not good as clinicians using existing criteria to predict who's going to ultimately have the biggest risk. And so, because of that patient, actually, I started to look and follow other patients who are getting hormonal therapy. Patients are living longer and longer and being diagnosed later and later with prostate cancer. The issue of competing risk in terms of both morbidity and mortality becomes an ever more important issue at the forefront of how we think as clinicians. There are patients that we meet that we think probably really needs hormone therapy, but we think we might actually be shortening their lifespan or causing significant harm to their sort of overall quality of life, that we have to really weigh this, should we do hormone therapy or not, right? But in order to make that informed decision, we also need to know who's going to be at risk.